So welcome everybody to this new webinar organized by the European Society of Contraception and Reproductive Healthcare. The webinar is conducted with the unrestricted educational grant from Organon, and I am presenting this webinar with Berna Dilbaz, who is professor in obstetric and gynecology at the University of Ankara, Turkey. Welcome, Berna.
Welcome, all the participants. I hope it will be a fruitful webinar. Thank you.
So before starting the webinar, sorry for that, there's a little problem that come with the starting new things, and we were no more used to stay online since the epidemic is over, so the pandemic is over, so we need to start again with what we were used to. So before starting, I want you to have some information on the European Society of Contraception and Reproductive Healthcare. The mission is to collaboratively work together beyond to champion evidence-based education and research in sexual and reproductive health, and all the rights, including facilitation for people, informed decision in choosing and using contraception. The objective of the society is to have an holistic education of sexual and reproductive health service providers in every country, and also to promote all types of research in this field, to collaborate with a range of non-governmental and governmental national and international organizations with similar objectives and values, and to remain the leading professional society in Europe in the field of sexual and reproductive health and rights, enhancing individuals and couple choice of contraception. If you want to join us, you can participate for €70 per year, and they will include the editions of the European Journal of Contraception and Reproductive Healthcare, regular newsletter, free access to webinar, a reduced fees for congresses and events. You can stand for election to the board, and you have also access to Doc Matter, which is an interactive community forum. I want you to save the new date for our upcoming virtual seminar, which is going to be held on May the 12th at 13th. And you will find all the information on the European Society website. If you want to ask questions, and for all the questions that we could not deal this afternoon, you can connect to ask questions and submit comments about this webinar on www.docmatter.com/ESC. And this is a community that benefits of ESC membership. So if you become a member, you have a free access through Doc Matter. As far as the practicalities of this webinar are concerned, please activate your question and answer, clicking on the button question and answer. You can also upvote each other questions, clicking on thumbs sign up. A selection of questions, of course, will be addressed after all lectures. And for those that we could not answer, please address them and add it to the HEST website. So it's my pleasure to introduce our first speaker, which is Professor Giovanni Grandi. He is assistant professor for the University of Modena and Reggio Emilia here in Italy, and he's also the editor-in-chief for our European Society Journal, which is the European Journal of Contraception and Reproductive Healthcare. Welcome, Giovanni, please.
Thank you, Manuela. I try to share my slides. Okay. So do you see my slides? Yes.
Perfectly, yes. Thank you, Giovanni.
Okay. Good afternoon. Good afternoon to all the attendants for this webinar. So today, I will try to explain in a modern view the management of irregular bleeding with different progestin-only contraceptives. contraceptives. So it's a very important practical topic in your daily clinical activities. These are my conflicts of interest of the last 5 years, but I claim full authorship for the contents of this presentation that was not founded by any pharmaceutical industry. So this is my first slides, and in my first slides are contained the main elements of my presentation. What are the progestin-only contraceptives? The progestin-only contraceptives are different because we have some progestin-only contraceptives that are ovulation inhibition, gives ovulation inhibition. For example, the pills in Italy and in Europe, in many countries of Europe, we have now a pill containing drospirenone 24+4 and or desogestrel 75 micrograms 28 days per month, and also the etonogestrel implants. So these POC are ovulation inhibition POC. But we have also other progestin-only contraceptives that are not ovulation inhibition, and these are the levonorgestrel intrauterine system at the different dosages of 13.5 milligrams, 19.5 milligrams, and 52 milligrams. Departing from this concept, this is my second concept. What are serum estrogen levels during the use of progestin-only contraceptives? If I use a progestin-only contraceptive that is ovulation inhibition, we have estrogen levels lower than normal of around a mid follicular phase. This is the study by Bertuizen, around 120 picogram mil. But if I have inside a levonorgestrel intrauterine system that is a not inhibition, the not ovulation inhibition system, we have estrogen levels almost normal. So in this slide there is the answer to our questions. If I use pills or implants, they need estrogens because they have estrogens levels lower than normal. If I use a levonorgestrel intrauterine system, levels of estrogens are almost normal. So they need really estrogens? So I will show you some data. Before starting my discussion, we have to clearly define what we are talking about bleeding during hormonal contraceptive use, because since the beginning we have this strange definition by the World Health Organization that defined the bleeding pattern based on the 90 days interval. That is a useless time interval, because they define 5 different patterns of bleeding: amenorrhea, infrequent bleeding, frequent bleeding, prolonged bleeding, normal bleeding. But what is the useless? What is the useful to think about trimestral bleeding? Trimestral is a concept for a pregnancy, but not for a bleeding during hormonal contraceptives. For hormonal contraceptives, we need data by a monthly pattern, because this is what is important for our women. And so this year it was published on Contraception a new definition of bleeding during hormonal contraceptive use that is defined in 3 different patterns. That is scheduled bleeding, scheduled bleeding are any bleeding or spotting that occurred only during hormone-free interval, so in the last day of the blister, so when women want to bleed. Unscheduled bleeding, that are the bleeding that the women don't want unscheduled bleeding normally, because are any day with bleeding spotting that occur during active hormone administration, so are unexpected. So women are unhappy with unscheduled bleeding. And the third pattern is the absence of bleeding spotting, what we can call also amenorrhea rate or silent menstruation rate. That is the absence of bleeding spotting, complete absence of bleeding spotting during the reference period. And so this is really interesting to see these slides, because you see that according to the regimen of the hormonal contraceptives that we can use, in this window, all the bleeding are unscheduled, but the scheduled bleeding, as you can see, are a bleeding that starts in the window. Also, if it starts at the last day of the window, this is a scheduled bleeding. Consider a scheduled. So now we have to pass to the real topic of my presentation: possible treatments of abnormal uterine bleeding during progestin-only contraceptives. And starting from this review published on the American Journal of Obstetrics and Gynecology in 2017, we can roughly divide the possible treatments in two big categories that are hormonal or not hormonal. And hormonal, I want that you immediately notice that we have studied using estrogens, using tamoxifen, that at the end is an estrogen because is a SERM that at endometrial level has an effect of an estrogen, and mifepriston, that is a completely different molecule, is a selective progesterone receptor modulator. So, but all these treatments are hormonal. Otherwise, we have some not hormonal, tranexamic acid, for sure, an antifibrinolytic agents, but also non-steroidal anti-inflammatory medication, we will see in detail, but also in antibiotics, doxycycline, maybe doxycycline could be an option to treat abnormal uterine bleeding, but when there is an endometritis cause of abnormal uterine bleeding, maybe due to chlamydia or something like that. But there are also some studies published about doxycycline. So now I go to the core of my presentation. So unscheduled bleeding during POP, so oral administration of progestin. My first slide is this one. If I have an abnormal uterine bleeding during the use of a POP, evaluate if the woman has a real contraindication to estrogens, because the first option is to switch her to a combined oral contraceptives. It's obvious. Okay, so the first thing is to evaluate if the woman has real contraindication. The most important contraindication according to WHO eligibility criteria are hypertension, are migraine with aura, are smoking after 35 years. Okay, if we have contraindication to estrogens use, so if we can't add estrogens to reduce the bleeding during the use of a POP, there is a new product that we can try. It was a real revolution in POP technology that we have in Europe since a few years. It is the first POP based on a new regimen, a 24+4 regimen. I see it like a French revolution in the market of POP, and it is the drospirenone only 24+4. So at the beginning, this 24+4 regimen was a bet, and I don't know if it was a winning or a losing bet. I think that at the end of the data that we have about this product, I can see that regarding bleeding is a winning bet, because drospirenone 25+4 in comparison to the other desogestrel pill is able to induce more scheduled bleeding, is able to reduce unscheduled bleeding during POP use, and also is able to induce more absence of bleeding. So at the end, a better cycle control. And I will show you now the data. So to reduce unscheduled bleeding versus desogestrel pill. This is demonstrating in this phase 3 trial published by Santiago Palacios. As you can see, in all the different cycles, 2, 6, 2, 9, drospirenone only pill 24+4 gives a lower rate of unscheduled bleeding. And this is true also for the quantity of day of unscheduled bleeding. So as you can see, the median and the mean of the day of unscheduled bleeding during drospirenone or desogestrel are significantly lower in drospirenone only. And also the occurrence of unscheduled bleeding, as you can see with drospirenone, the occurrence is high because it's not the 1%, it's 40%. But with desogestrel only pill, it's 50–60%. So there is a decrease in occurrence of unscheduled bleeding. And also another advantage is the effect on prolonged bleeding episodes that are the real tricky for our patient, because there are bleeding episodes that last for more than 10 days. And considering this issue, as you can see, drospirenone only pill is significantly better than the desogestrel 28 pill, with significant p-value in all the 9 cycles evaluated. And so reduce unscheduled bleeding, but also can induce more scheduled bleeding. The scheduled bleeding are in this graph represented at the end of the blister. As you can see, the rate of scheduled bleeding is not so high, it's around 20–40% per cycle, not more, but at the end, it can give also more scheduled bleeding in comparison for sure to the desogestrel pill that normally doesn't give scheduled bleeding. and also amenorrhea rate with drospirenone only pill, so silent menstruation. You can see it's around 30% in the first 5 cycles, and it passed to 40% from the cycle 6. And this rate is higher than what we see with the desogestrel 75 micrograms pill. This is an old study based on a old reference period of 90 days, but for amenorrhea, this is not important. The rate of amenorrhea during the desogestrel only pill is 20%, so the half of what we have seen with drospirenone only pill. And the breaking news that I can bring to you in this European Council is a study that we have published 1 month ago on the archives of gynecology and obstetrics. It's the first study that find a correlation between the features of the menstrual cycles before to start a drospirenone only pill and the cycle that occurs during the beginning of drospirenone only pill. So in this study, we give to the patients a diary to complete the 2 menstrual cycles before to start drospirenone only pill. And what you can say is that women with absence of bleeding spotting during drospirenone only pill are the women that before to start this pill have a normal cycle of 28 days. Women with scheduled bleedings during drospirenone only pill are women that during the 2 cycles before are the longer cycle lengths. So to have a longer cycle length, it is a mean, obvious. It's a predictive to have a more scheduled bleeding during drospirenone only pill. And on the other side, women with unscheduled bleeding during drospirenone only pill are women that in the basal cycles have the shorter cycle length. So if a woman has shorter cycle length of 25, also before to start a DOP, it will be more probable to have also unscheduled bleeding during a DOP. So to conclude this first part of my presentation, if I have an unscheduled bleeding during a POP, oral POP, if it's possible, switch to a COC, so a combined oral contraceptive. So just reevaluate if the patient has really contraindication to estrogen use. If she still need or prefer a POP, try to change to drospirenone only pill, because we see that it has a better pattern of bleeding in comparison to the desogestrel pill. Otherwise, change to another progestin only contraceptive, such as implant or levonorgestrel. IUS. So we go to the second theme, to the second important topic, unscheduled bleeding during implants. So we change completely the way of administration. And I want to show you this wonderful study published by the group of Professor Farris and Professor Bastianelli and Professor Benagiano. This is a very huge review about the effects of progestin-only contraceptives on the endometrium. And I show you this data because what I want to show you is if we use an intrauterine delivery or a subdermal implants, we give to endometrium completely different changes in both the components of the endometrium that has epithelial and stromal cells, but also in the vasculatory pattern on the endometrium. If I give an intrauterine delivery, I act both on glands and stroma, giving an atrophy of the glands and a decidualization of the stroma that you can see here in this microscope imaging. If you give a long-acting subdermal implants, you give a complete different modification only of the stroma with an edema of the stroma, so no decidualization. And also, as you can see, there is specific changes in also the vasculature given by the 2 different routes of administration. So to give progestin in different way, it can give completely different effect on the endometrium. So to start, what is the menstrual pattern during implant users? This is the old study by Diana Mansour, published some years ago, that describes very well what is the pattern that we have to expect during the use of implants, etonogestrel implants. And as you can see, women in general, passing the time will ameliorate their bleeding pattern. Okay, the bleeding pattern will be better passing the time. So they will have not frequent bleeding immediately in 40% of the cases, decreasing to 35%. 40% as normal bleeding, increasing at 52% at the end of the use of the implants. Amenorrhea rate is quite sizable, around 20% during the use of implants. But we have the problem. The problem is women experiencing frequent bleeding that are around 10–20% from the beginning. These are the women that we have to treat. And if we see, it's very interesting also to see the study by Diana Mansour, because it's immediately evident that depending on the different also cultural behavior of the different patients included, the rate of discontinuation for bleeding irregularities is completely different. For example, is higher in Europe and in US, and it's quite lower in women from, for example, Asia. And this is what I see also in my clinical practice. So it's not the case. Maybe because they don't have this important bleeding, or maybe they live with this with this problem of bleeding in a different way. But at the end, they discontinue in a lower possibility with implants. But who stops for bleeding irregularities using implants? Two categories: women with have frequent bleeding and women who have prolonged bleeding. This is obvious if you think about that. So now I want to introduce you what are the new way of see these problems. And the new way to see this problem, it seems that it derives from the etonogestrel serum levels. Okay. This is a very important study published in 2019 on obstetrics and gynecology, showing that if the serum level of etonogestrel increase in the plasma of our patients have an increased risk of reporting abnormal uterine bleeding, and also an increased risk of having received the prescription as treatment for bothersome bleeding. So higher level of etonogestrel, high probability of abnormal uterine bleeding. And another study published by the same American group on contraception journal gives us other elements, because gives us the elements that the levels of etonogestrel are inversely correlated to the months of implants use. And this is correct, because I told you before that passing the time, the bleeding pattern are always better. So the etonogestrel levels decrease and the bleeding patterns ameliorates in our women. The etonogestrel levels are inversely related also to BMI of our patients. So this means that fatter women have better bleeding patterns than thin women, okay? On the other side, we have a Black African woman that has a direct relation with etonogestrel levels. Maybe in these women, the bleeding are more problematic because they have, for a genetic maybe predisposition, higher level of etonogestrel. So we will be more disturbed by bleeding pattern. We have finally understood, maybe during first months of use, this is true, Black African women, maybe yes, and also thin women. Obese women have not this problem, or have this problem in lower degree. This is very important theme for our counseling. And this is demonstrated also from an Italian study by the group of Professor Di Carlo of the University of Naples. As you can see, group A were women using implants with a good bleeding pattern. Group B is women using implant with a bad bleeding pattern, with prolonged bleeding, with frequent bleeding. If we see, the only difference between group A, group B is the BMI. So women with a good bleeding pattern are the fatter. Okay, so this is confirmed by our study. And I'm reviewing another study published for an important journal coming from the US, showing exactly the same data. So BMI is a protective factor for abnormal uterine bleeding during implant use. So what we can say, so starting from these things about bleeding management of etonogestrel implants. In 2011, so 11 years ago, this review by Diana Mansour again start from a good diagnosis of why the woman is bleeding. After the good diagnosis, she proposed some bleeding management. But as you can see, all these bleeding management are as supportive evidence, really little published evidence, anecdotally, no published evidence, anecdotally. So are just advices, not more than advices. First choice, a COC for 3 months, taken 21 days plus 7 days of break. Second choice, high dose cyclical progestins for up to 3 months. Third choice, a POP, a desogestrel POP. Fourth choice, NSAIDs, non-steroidal anti-inflammatory drugs. Fifth choice, tranexamic acid. After 11 years, I can say that we can remove one choice, that is the third choice, because we have seen that to increase the level of etonogestrel, it's not a right choice, because desogestrel is completely metabolized in etonogestrel. So if we give to women using an implant more desogestrel, we cannot reach a good objective. Okay, so today, 11 years after, I propose the sixth choice. That is, again, where we start. We start proposing that we need estrogens in these women, okay, in this type of POX. So my sixth choice is transdermal oral estradiol, 1-2 milligrams per day for a week. And this is not only my idea. We have some data emerging in the literature showing that, for example, with the use of tamoxifen we've seen before is a SERM that has an agonistic activity on the endometrium. This study published in 2020 show an effective of tamoxifen in comparison to placebo. Tamoxifen, 7 days of tamoxifen, 10 milligrams, 2,000 days. Okay, so we have a placebo-controlled study showing that this could be a good option for the treatment of bleeding during implants. And a second study that I want to show you, it was a study published on Howard Journal 6 years ago, in the comparison between the use, again, add an estrogen, again, the use of ethinyl estradiol plus levonorgestrel versus placebo. You see that in the group treated with COC, all the subjects that are not very much, but all the subjects, 11 improved significantly, 1 improved slightly in comparison to placebo. So an effect demonstrated also by the study. And also the study coming from the Japan. In this study, in my mind, they used the worst contraceptive that they can use, because they used the combination with ethinyl estradiol 20 micrograms plus desogestrel. So this is enough. I will prefer to use a different progestin, not desogestrel, and maybe a quite higher dose of ethinyl estradiol. But also, if they use this type of contraceptives, they give more effect in comparison to the use of non-steroidal anti-inflammatory drug, around 75% of good outcome. So the bleeding management during an implant, from my side, starting from the beginning, from my hypothesis, are that we have to add estrogens. So we can add transdermal oral estradiol, 1-2 milligrams per day. We can add tamoxifen, 10 plus 10 per day. We can add the 3 cycles of combined oral contraceptives, but I prefer no with desogestrel or etonogestrel, but I prefer to use more progestin with high uterotropic index, such dienogest or normegestrol acetate. If we have a contraindication to estrogen use, and we can't use estrogen, so add a progestin alone. But again, in my mind, it's better not to add desogestrel or etonogestrel. It's better to add other progestin, dienogest, normegestrol acetate, noretisterone for 3 cycles. This is my bleeding management during implants. And this is another important thing. There is no sense to try 3 months of a POP with the desogestrel to see what bleeding occurs before putting an implant, because the pharmacokinetic of desogestrel and etonogestrel by oral or transdermal administration is completely different. So it's not an acceptable trial before starting implants. And this is a very important issue for implants, especially if the implants is used for the treatment, for the long-term treatment of diseases such as endometriosis, in which we need a perfect cycle control. A woman with endometriosis that has an implant on site and starts to have a prolonged and frequent bleeding, she's not happy. She's not happy with the treatment. So it's very important, this bleeding control, also for the long-term treatments of chronic disease such as endometriosis. So the last topic of my presentation is the management of unscheduled bleeding during the use of levonorgestrel intrauterine system. So we start from the questions. Levonorgestrel intrauterine system are not ovulation inhibitory system. So they have normal, almost normal estrogens level. So do they need really estrogens? The first slides show you that the occurrence of unscheduled bleeding during the use of different dose levonorgestrel intrauterine system are mainly in the first 6 months and are not so frequent as in implant users. As you can see here, with the levonorgestrel 90.5%, this is a study by Christina Gemzel. As you can see, the rate is 4%, decreasing to 2%, prolonged bleeding only 5%, decreasing to 2%. So apart the first 90 days after, this occurrence is very, very, very low. So the problem is not so important as when we use implants. And another important slide that I want to show you, this is a study by Mission Training published on contraception, showing that at the end, the high dose levonorgestrel intrauterine system is associated with a better bleeding pattern profile in comparison to the lower dose levonorgestrel intrauterine system. This is true for amenorrhea rate, more amenorrhea rate in comparison to the lower dose, but also unscheduled bleeding, lower rate of unscheduled bleeding during 52 milligrams in comparison to the lower dose levonorgestrel intrauterine system. Because in the higher dose levonorgestrel intrauterine system, we have really, really high rate of amenorrhea. This is the last study published on the American Journal of Obstetrics and Gynecology with a follow-up of 8 years with the use of levonorgestrel intrauterine system 52 milligrams, showing a rate of amenorrhea at the end of 40%, with a very, very low incidence of discontinuation due to irregular bleeding, always lower than 1% of users. So what to do? What to do when I have an unscheduled bleeding with a levonorgestrel intrauterine system? This is a systematic review that we have published in 2020 on our journal, showing all the study published about this topic. As you can see, the majority of these 8 studies show no effect of the treatment used. And mainly of these trials are not for the treatment of bleeding during a new occurrence of bleeding, but from the beginning to avoid the bleeding at the insertion. So it is quite a different study questions. But the study that's showing something, what's showing to us? This is the most important study published in the US. This is again a study investigating at the beginning. So when I place a levonorgestrel intrauterine system, and they randomized women in 3 groups: naproxen, 500 milligrams, 2 tablets daily, 5 days for each monthly period, okay, for 3 months; placebo group, and estradiol 100 micrograms transdermal group. Okay. As you can see, the only effective treatment is naproxen. So the anti-inflammatory drugs that is better than placebo in reducing the day of unscheduled bleeding. Estradiol, adding estradiol, the situation go worse. Okay, so we increase the rate of bleeding of our women. So this is a very important message. We add estradiol, no benefits. Again, you remember, we have demonstrated that the use of tamoxifen can ameliorate the bleeding pattern in etonogestrel implants users. With tamoxifen and levonorgestrel intrauterine system, no effect in comparison to placebo. So again, also the use of sperm does not help in the treatment of abnormal uterine bleeding during levonorgestrel intrauterine system. And another drug, this is a very important trial published by the group of Christina Gemzel and Elena Kopp-Kalner from Karolinska Institute. As you can see in this trial, they use placebo versus mifepristone, and patients take these drugs 1 month before the insertion of the levonorgestrel intrauterine system and then start the treatments for 6 months. As you can see, the effect of mifepristone in reducing, so a selective progesterone receptor modulator, in reducing the bleeding is effective before patting the levonorgestrel intrauterine system. When we pat the levonorgestrel intrauterine system, completely no effect in reducing abnormal bleeding. So also mifepristone, no effect on this issue. So the conclusion of the systematic review published on our journal are that in general, we have very few data. But what we can say that for prophylactic treatment of bleeding spotting immediately after insertion, we have high level of evidence for only this aryl-propionic derived non-steroidal anti-inflammatory drug. No evidence for any hormonal treatment. So to conclude, I think that I start from an hypothesis and I try to demonstrate that my hypothesis could be a good way to follow. In POP users, POP is an ovulation inhibition method, so we need estrogens. Okay, so if it's possible, switch to a COC, reevaluate contraindication to estrogen use according to the World Health Organization medical eligibility criteria. If she still need prefer a POP, change to DOP, drospirenol pill associated with a better bleeding pattern. Otherwise, change to other progestin-only contraceptives. Implant users, again, implants inhibits ovulation. So again, we need estrogens, option, estradiol, transdermal oral, tamoxifen, a SERM, combined oral contraceptive containing, I prefer to use combined oral contraceptives containing another progestin, no desogestrel or etonogestrel. Obviously, if there are no contraindication to estrogen use, again. But with levonorgestrel intrauterine system, we have to say that in general, we have lower risk of abnormal uterine bleeding with the use of these types of progestin-only contraceptives, but they are ovulation, not inhibition contraceptives. So do they need estrogens? Probably not. In fact, we don't have any published data showing an effect of estrogen. So we have only few data about the possible use of naproxen, a non-steroidal anti-inflammatory drugs, in the 3 months after placement. I want to thank you very much for the attention. I want to wish you a very Merry Christmas. And I have a special desire for the next year. We are in the continent, we are in the Europe, and my first desire for the next year is peace in Europe again. So thank you very much. And I'm open for the last session of question and answer. Thank you.
Thank you,
Giovanni. And I will leave the word to Professor Berna, who is going to introduce the next speaker.
Our next speaker is Dr. Farah Chaudhry. Actually, she's not going to be with us online, and she has just sent us a video presentation about tips, tricks, and troubleshooting for implant removals. So Dr. Chaudhry is a consultant of sexual and reproductive health, and she is currently working as co-medical lead at Lead Community Healthcare NHS Trust at UK. She is a panel member for Faculty of Sexual and Reproductive Health. So if you have questions, they can be addressed at the European Society of Contraception website or DocMatter forum. And also, we are lucky to have Dr. Giovanni here. So he's also an expert on implant removal. So we'll watch the video presenting tips and tricks and troubleshooting for implant removals.
And good evening from a very cold, wintry evening in the United Kingdom. My name is Farah Chaudhry. I'm a consultant in sexual and reproductive health in the United Kingdom, and I work as co-medical lead at Lead Sexual Health. I'd like to say thank you very much to the ACA for inviting me to speak this evening. I'm going to start by sharing my screen. So the title of my talk this evening is Tips, Tricks and Troubleshooting for Implant Removals. And I want to share with you some of our experience collectively as a service, then from me individually, personally, through the experience that I've gained over the years. This is my declaration of interest. I am the GTPD, or General Training Program Director for Organon in the UK. And this is a little bit about my service, Lead Sexual Health, and to really illustrate the qualification that I have to speak tonight, really. We're the only deep implant removal sexual health service in our region in Yorkshire, in the United Kingdom. We're very, very fortunate to have 2 SRH consultants that are deep implant, complex implant removers. We also have 2 very, very talented trainees that are also being trained to remove the complex implants as well. We also contribute to the expert removers group nationally, and earlier this year in Ghent, we were invited to speak at one of the evening meetings because we've been recognised as a centre of expertise or centre of excellence within Europe to help try to share our learning with other prominent centres throughout Europe as well. So towards the bottom of that page is looking at our deep implant removal figures. Mine averaged between 60 to 90 a year. And then of course, as you look down that table, you'll notice the COVID effect where the figures were very, very low, 2020 and 2021, but now in 2022, I've already reached the 67 mark. 75% of these are out of area, which shows what an important service it is for the region, really. And remember, this represents only half the service because there are 2 of us. So if you're looking at a service as a whole, you can double those figures and get a rough estimate of how many we see in our service. So starting off, before we get to the actual practicalities of removal, dealing with requests for early reversal, I think deserves an acknowledgement and a discussion because it's very, very important. Commonly, it's because of perceived side effects. And in my experience, the commonly reported side effects are as illustrated on this slide: bleeding, acne, bloating, headaches, breast tenderness, nausea. I think bleeding, acne are the 2 main reasons for early reversal that I have experienced, and sometimes perceived weight gain as well. So we'll deal with each of those very briefly in a little bit more detail. The first thing we have to do is actually acknowledge which side effects are biologically plausible and evidence. And this is actually a screenshot from the specific product characteristics, SPC, and one should always refer back to this to see, is this a plausible, recognized evidence side effect associated with this method or not? And you'll see that acne certainly is. The weight is in there as well, but you've got weight increase and weight decrease. And I certainly think bleeding irregularity is the commonest that patients will come back with, really. So what's going on in this interaction when patients come back to you? Well, the patient is strongly influenced by their personal experience, obviously, and they're strongly influenced by anecdote. So what their friends or family might have perceived or experienced will strongly influence their belief and expectations of the method. If somebody who's trusted by them, it feels very strongly that it causes weight gain with them, it's very difficult to overcome that strongly held belief and persuade them otherwise. But there are always media influences as well. Increasingly in the past few years, we've seen the influence of social media and of course the general media as well, with periodic pill scares, which do influence health-seeking behavior. As healthcare professionals, we're humans also, so we are also influenced by personal past experience, our professional practice, as I've explained to you today. This is what I see a lot of patients coming back and complaining of. But really what we should be focusing our energies on is the data, biological plausibility. So my advice to you is to refer to the SPC and the CEU guidance. So how to deal with hormone hesitancy or apprehension, suspicion of hormones causing symptoms, perceived or real. So be very honest, don't be dismissive of these symptoms and acknowledge their concerns. Give them factual, realistic advice. Don't overpromise and say, you know, if I remove this, any weight gain that you've experienced is automatically going to get reversed. Of course not, we cannot promise that. So never say never, never say always, and avoid giving either fake news or false promise about these methods. Just give them factual information based on the SPC and the CEU. So is there some truth to hormonal side effects? Well, yes, some women will experience hormonal side effects, but one of the strongly reassuring arguments that I have is that you look at the dose, because one could argue, and it is biologically plausible, that hormonal side effects may well have an element of dose dependency. And if you have a look at where the implant sits in terms of the dose or the dosage ladder, it's very low down on the ladder. The only thing that sits below it is the levonorgestrel containing uterine system, and the implant is the next lowest dose. So it's not a no hormone method at all, but it is a low hormone method, isn't it? And that I think can reassure. So let's look at some of the commonly complained of side effects where women come in asking for early reversal. Mood change, well, look at the faculty and the SPC. It says that there's limited evidence that causation is not established. And that's the take-home message. Let's consider now weight gain. The evidence does not establish that the ENG implant causes weight gain. They've also looked at it from the other perspective, really. Does the concept of efficacy of the implant diminish with increasing BMI? Because this was a concern at one point, but now the faculty guidance in the UK has come down quite strongly on the side of the available evidence suggests that contraceptive effectiveness of the implant is not affected by body weight or BMI. There's also been a guidance specifically for women who are overweight and obesity, and again reiterates that message: no evidence of causal causation between implant use and weight gain. So I think I would like you to go away feeling very reassured by this. Unpredictable bleeding with the implant is a problem. This is a big problem, and I know one of the speakers from earlier this evening has covered this, so I will keep this very, very brief. It is very, very common, and I think the take-home message is that please be very, very honest and open in your counselling, manage expectations, never overpromise, explain that the bleeding is variable, unpredictable, and may well change with time. But be open to that discussion. Ask them to come back and let you know if there's a regular bleeding, and do exclude pathology before discounting it and just blaming the hormone. But then once you have excluded pathology, whether it's an STI or disease of the cervix, reassure them that this bleeding is not harmful or dangerous, but it is a nuisance. And actually you can do something to help and intervene. And the type of things that we try to do are perhaps add in a CHC for 3 months. If it explain that this is off license, it may be used continuously or cyclically. I also, if they cannot take combined hormonal contraception or they do not wish to, I do use a desogestrel on top as well. Again, off license use. You may choose to just wait it out and see what happens if a woman is adequately reassured. But I tend to find if you intervene earlier or offer to intervene earlier, you get less disengagement and disenchantment with that method. And if things are really not tolerable or they're not getting better when you have intervened and offered medical management, perhaps accept that maybe this isn't the right method for you. Perhaps we should look at other things. So now turning towards the procedure itself and implant removals. No discussion about implant removals would be complete without acknowledging the importance of a good fitting technique. And this is screenshots again from the SPC, reminding of the importance of choosing the correct position for implant fitting. So it should be 8 to 10 centimeters medial, proximal rather to the medial epicondyle, and 3 to 5 centimeters posterior to the sulcus. So the reason for this is because we're trying to avoid that extremely important sulcal area where the neurovascular bundle travels. So my advice to you is fit in the right place, fit superficially, avoid the sulcus. General tips for examining when women come in for removal is always start off by looking at the dominant arm, looking at the medial aspect. It should be 8 to 10 centimeters proximal to the medial epicondyle, as it's explained, and posterior to the sulcus. You can also be governed, of course, with patient recalls. You may well, hopefully, remember which arm it was fit. And if it is difficult to palpate, can they remember if they were in a funny position when they had it fit? I've had people come in saying they were in an upright sitting position, which I do find very, very worrying, because that is not according to the SPC and the manufacturer's recommendations of faculty training. But you know, if you recreate that position, you can sometimes help you locate the implant and palpate it. If the scar is visible, start there and then work proximally and distally, gradually increasing the range of examination. Is it safe to remove? This is a very important question. So ask yourself, can you feel the length of the implant? Can you feel both ends? And also, this is a very important sign, the pop-up sign. So you press on the proximal end gently, and then you should be able to elicit this pop-up sign where the distal end pops up through the skin. You can see it sometimes and feel it. And that is a very powerful marker of you being likely to be able to remove it safely. Also consider, am I happy to go into it according to the position it's in? If it's very sulcal, I would warn caution really. If it's very axillary, very proximal, brachial plexus territory, be careful. If it's at the elbow, very distal, ulnar nerve territory, be very, very careful. There are also patient factors. I would say to beware of the very, very slender thin arms. Very, very careful, because it's not difficult to inadvertently fit deep. They've got very little subcut fat, and you can inadvertently hit fascia or breach fascia quite quickly. And with larger women in obesity, they can be difficult because you've lost your anatomical landmarks for a bit, and sometimes it's finding the implant and manipulating through the tissue. The other things to consider with patient factors are, comorbidities. Are there an anticoagulation? Remember, if there are, the faculty guidance is an experienced clinician should perform the procedure, and the procedure should be scheduled to coincide with the lowest anticoagulant effect. So if they normally take their dose in the morning, you want to be fitting them into the clinic for the procedure at the end of the day, that type of thing. Avoid non-steroidals as well for pain relief, because you want to minimize bleeding. And women with bleeding disorders, if their platelet count is over 50, it's deemed to be safe to remove in a community setting. If their platelet count is under 50, or they have an inherited bleeding disorder, really should liaise with the hematologist and get advice on a case-by-case basis. So the removal itself, prepare, make sure that you have valid consent, and it's robust consent, which explains the risks of the procedure, including scarring, infection, potential for neurovascular damage. Position the patient adequately. This diagram illustrates beautifully the position that we're supposed to have the patient, and particularly for insertion. What I find is that for insertion, you should position yourself, beg your pardon, let me just go back a slide. You should position yourself here so that you're perpendicular at right angles to the patient's arm. But when I remove, I tend to position myself here so that I'm kind of in line with the arm, because it's easier to manipulate the implant in this direction. Remember, you're using an aseptic technique, have the right equipment. You're as good as the equipment really when you're doing surgical procedures. So local anesthetic, lidocaine 1% is the faculty recommended and the manufacturer recommended anesthetic. For my complex removals, I do use lidocaine with adrenaline because it gives me a plateless feel, and the adrenaline potentiates the action of the lidocaine, makes it last a little bit longer. I use an orange needle because I don't want a big blob of local anesthetic. I want a small amount of anesthetic, and this is very important, is careful, skilled application under the distal tip of the implant. It's not how much you use, it's how you use it. You don't need to use vast quantities, but it does require skillful application. If you apply a large amount of anesthetic, but if you go over the implant, you're making it more difficult to palpate. And you're pushing it further away from you. As if you insert the needle just underneath the tip and infiltrate there, you're actually raising the implant up towards you, further away from the deeper structure, so it makes it safer and it's facilitating removal. So the equipment, I actually like the 15 scalpel blade, which is the curved one, but most people use the 11. The mosquito forceps, again, you can use straight or curved. I like the curved. They're just more elegant design. I find them easier to manipulate and control. And the bottom one here, the modified vasectomy forceps, is my real go-to with complex removals, whereas I'm not always going at the tip, at the distal end. This is fantastic. As you can see, it's got that little hoop at the bottom end, which is perfect shape and size to grasp an implant. So having the right equipment really is so vitally important. So personal tips from me to you when it comes to removal: careful control throughout the procedure. So stabilize the implant by pushing down the proximal tip so it doesn't move around and you're holding it still during the procedure. I've witnessed people do this, push the implant down and distally. When you do that, when you let go of it, your implant has moved away from your incision site. Don't do that, go straight down. So you're going straight down towards the floor, perpendicular to the implant. Don't avoid pulling the implant down the arm or more distally down the arm. And this also, of course, helps accentuate that pop-up sign, and then you can gently incise over the top end over the bottom end of the implant rather, and help remove it. This is a small 2 millimeter vertical incision of the distal end, vertical because it's better for healing cosmesis because it follows Langer's lines. And really, this is a technique of manipulation. We're manipulating that implant out, and we're using our fingers and manipulation more than we're using the sharp instrument in your hand. You're using the sharp instrument to reveal the tip of the implant, but then manipulate it out as much as you can. You may need to use your scalpel again to help release the implant from the sheath that covers it as part of the kind of healing response. But really, I would encourage more use of your hands than sharp, pointy instruments. It is a blunt dissection technique, which is really, again, reinforcing what I've just said. Use steri strips to dress the wound. I prefer brown because they're better. I think they give better cosmesis. They have more elasticity to them, so you get better tissue tension over the wound, and careful acknowledgement of aftercare. We have an aftercare leaflet that we send to patients saying, keep the bandaging on 2 days, keep it clean, keep it dry, don't let it get wet in the shower, then remove the bandage, but you may leave your steri strips on for 5 to 7 days. If it's red, itchy, hot, swollen, weepy, or you're getting any symptoms in your fingers, seek medical attention, that type of thing. And I think it is very important to have that, because we give them so much information in the consultation that, in fact, they're not going to recall it all. Having an aftercare leaflet that you can send to them really helps. So I'm just going to share a little bit about our deep implants with you. If somebody comes to you, presents to you with an impalpable implant or a very difficult to palpate implant, do examine both arms. This sounds like an idiocy, but actually it's very, very important. I've had quite a number in my career where it was actually in the other arm. If it's fit over the biceps, examine proximally, because they tend to migrate more proximally. If it is fit in the triceps area, examine more distally. Do not attempt to remove the implant if you're not confident you can get it out. If you're not sure you can feel it, or you're not happy with its actual position, it's too sulcal, it's too axillary, please refer to an expert removal center. It's safer for the patient, and also it's much more difficult to remove it if somebody's already attempted. It's the scar tissue. Beware of very thin arms. It can be very misleading and lull you into a false sense of security. They can be deeper than you think, nearer important structures than you think. And if you can't palpate, remember to cover for contraception whilst they come to see us. In the same way that if somebody presented with lost threads and you're trying contraception, you would cover them with contraception whilst you ascertain that it is indeed in situ. So what is the purpose of scanning? Well, it's to prove that the implant is indeed present, but also to assess its positioning. What anatomical structures are in the vicinity? Is it safe to remove in a community setting, or is it indeed in the patient's best interest to leave it in situ? So it is a difficult scan. It's like looking for a needle in a haystack. It's a foreign body, which is hyperechoic, and it has this kind of very characteristic footprint, this acoustic shadow, because it's a foreign body. So ultrasound waves can't pass through it. And really it's the acoustic shadow that helps us locate it. But then we put on the color flow so that we can demonstrate what the nearby structures are and make sure that it's not overlying the brachial artery or something like that. Remember, management of deep implants as well, it's complex, it's difficult. We believe that the rate is between around 8 in 1,000 according to the NORA study. And it's important, we've introduced that in our counselling. As I've said already, palpate both arms, then we will go on to scan both arms, we would then go on to x-ray both arms and organise a chest x-ray to exclude distal migration. And if we still haven't located this implant, the next step would be ENG levels, which we organise through Organon in the UK. Remember again, alternative contraception will establish if it's in situ, but there is a washout period if you're going to do ENG assays, so you need to corroborate with the lab and establish what those washout periods are. In more recent faculty guidance on implants did include a section regarding management of deep implants, where they acknowledge that some individuals may opt to leave a deeply sited implant in situ indefinitely to avoid the risk of structural removal. And why not? If they don't want their fertility back, and if that isn't a concern, they're willing to accept alternative contraception or another implant in a different site or the opposite arm, and they're not worried about migration because you can establish exactly where it is, then that is something that can be offered. So my key points to you tonight is that counselling is of utmost importance to prepare the patient to improve continuity and continuation with the implant, but also in terms of preparing them for what the procedure may be like and possible complications of the procedure. A good vetting technique really is the key to making removals better and safer as well. When somebody attends for removal, do consider very carefully, is it safe and appropriate to remove in your setting? Always remember to work within your competency and familiarise yourself with expert removal centres. Know who you can go to, know who you can refer to. So thank you so much for listening. And I'd like to take this opportunity again to say thank you for inviting me to speak tonight, but also to wish you season's greetings and a prosperous and happy new year. Thank you very much.
So we are at the end.
So we thank also Farah Chaudhry for being here with us, even though she was just on video, but it was a really interesting presentation. So I would like now to start with the question and answer moment. There are 2 posted questions since now. We wait for the others. Maybe there is someone that need more time to decide whether it wants or not pose some question. So the first question is for Professor Giovanni Grandi, and is concerning the bleeding with ethanogestrel implant. You said that it's better not to use a desogestrel only progestin pill on the basis that it can make ethanogestrel level higher than what they are in general, and this can cause more bleeding or not solve the bleeding problem. So what would you consider about the need, for example, for a greater ovarian suppression?
Yeah, I think that regarding this question, I'm really I see many times during Congress to this proposal to add the desogestrel only pill in implant users bleeders. But I have to say that since now there is no one publication published in the literature showing an effect of a POP containing desogestrel on these problems. I don't know why this advice was driven, because there is no any evidence about this advice. So obviously I pose an hypothesis. We need more data, but I think that these initial studies from the Americans about the level of ethanogestrel and the bleeding are really interesting, and we have to follow this idea, because they can give us any element. So And I think that to give a perfect ovarian suppression, it's not important to add more and more and more and more and more progestin, but also to use an estrogens combined, because the estrogens combined can inhibit the follicular growth. So, and with the progestin alone, you are not able to inhibit the follicular growth because you don't act to on the gonadotropins. So my message is I don't have data, clearly data to show, but what I have shown tonight is that the few data that we have is to add estrogens, to add tamoxifen, to add estrogens like substances. Now it's just an hypothesis, it's not an idea, but I think that we have to follow this idea to reach new data about this important issue, unresolved important clinical issue.
So there's another question, Dr. Grandi. It's about this first generation POP, norethisterone only pill, Migranol.
Yeah. This is,
yeah, you can see the questions about the estrogen levels and rates of unscheduled bleeding with this old-fashioned POPs.
This is a very important question because I don't have in Italy this pill, but this pill is a real mini pill. It's time today to use the right words. In the word of POP, we have mini pills that are one thing and POP that are another thing. POP are ovulation inhibition drugs. So we have desogestrel because it's used at 75 micrograms and the dose to inhibit ovulation is 60 micrograms. And we have drospirenone that we use at 4 milligrams and the dose of inhibition is 2 milligrams. These are POP, real POP. Mini pill are completely different entities because, for example, this pill that are we talking about with norethisterone 350 is not an inhibiting pill because the dose to inhibit ovulation with norethisterone is 0.5, 500 micrograms. So during this type of pill, the level of the estrogens are not really reduced as when we use an inhibiting progestin pill. Okay, so maybe this type of pill are more similar to a levonorgestrel intrauterine system than a POP or an implant. So maybe I think I have never used this type of pill, but following my hypothesis, for this type of mini pill, it's not useful to use estrogens. Maybe we have to use different things because level of estrogens are higher because ovaries are not inhibited. So we have to start to thinking new things about POP, mini pill, dose of ovulation inhibition. So this is the where we have to work in the next years, I think.
Yeah, the problem with this sort of mini pills was not the bleeding. It was, you know, if there's a delay more than 3 hours, they were ineffective. So that's why the POPs came into fashion or more used. So more questions, Manuela?
Yes, we keep on going. Good morning to Dr. Tadzimoye Crawford, which is following us from Jamaica. And he wants to have more information about the mood change as a side effect with the implant and want to have some information on that. I think that if Giovanni wants to answer, otherwise I can answer to the question, or Berna, if you want to participate and answer with the question.
Yes, as with any hormonal contraceptives, we can have women showing mood changes also with implants. So if the mood changes happening, but mood changes can happen also with the levonorgestrel intrauterine system. So it's dependent maybe more on a personal predisposition to hormonal contraceptives than to the contraceptive itself. I have also in my experience some women that try to remove the implants by themselves and come to our emergency gynecological room with because they were not able to do that and they cut the And now I know that there are some Italian groups that are proposing for this type of women to put the implants in other side not reachable by the women, especially for psychiatric patients, for example, on the back. Yeah, this is another interesting issue that we will have to follow in the next year. So, Manuela, do you have some specific more details about this question?
No, I perfectly agree with you. So as was the answer that I was going to give, I mean, that those women who are more prone to depression can have more moods change with any kind of contraception, actually.
And also self-removal should also be told not to be done. We had only one patient who tried to remove, and the implant, it was the only case I had so many insertions. The implant was broken. So we really had difficulty in taking it out. So when we're talking about insertion and removal, we should always say never try to remove it by yourself, especially if someone is obsessed with that.
So we have some greetings for the excellent webinar and some congratulations from Professor Franca Fruzzetti, who is asking whether you suggest 7-day estradiol therapy for 3 months and no more than 7.
Yeah, this is just, I have to say, copied by the studies with tamoxifen. Tamoxifen was demonstrated effective after 7 days of use. Yeah, yeah, we have to work about it. But yeah, what I found in the literature about, for example, tamoxifen proposed a treatment of 1 week per month. So I translated estradiol, but yeah, we have to demonstrate. But I repeat, all these are hypotheses, are based on anecdotal experience and are just proposal. Also, we are a society, we can do studies also together. So I'm completely open, and this is not what I show you tonight is just the few data that we have in the literature, very few data.
We have another question, and it's about the higher BMI and better bleeding profile. And Dr. Chaudhry is asking whether it is related with the increased peripheral estrogen production in patients with higher BMI, or is it related with desogestrel?
I don't know for sure. In higher BMI patient, we have lower etonogestrel level. This is clearly demonstrated in I think 5 or 6 trials. So this is for sure true. Lower etonogestrel levels, because you know the adipose tissue is also a lipophilic tissue. So it takes from the periphery the progestin, and the progestin is very lipophilic molecule. So the progestin goes in the adipose tissue. So this is why it's not in the serum. If it's also for this higher estradiol level, maybe it could be maybe both things put together to give this effect. It would be really interesting to study also the estrogen levels. Maybe for the effect of peripheral aromatase that can change androgens in estrogens, maybe in the adipose tissue.
The second part is actually Sharon made the same comment. You didn't favor an oral contraceptive with desogestrel. I think that just needs more explanation. Did you think desogestrel doesn't provide enough endometrial stability? That's why you were talking about the study with 20 microgram ethinyl estradiol with desogestrel, and you thought that treatment wasn't very successful. Do you think you should prefer like Dynogest, which is more strong in providing endometrial stability?
Yeah, this is my idea. In this specific field, it comes from 2 ideas. So not add desogestrel and etonogestrel, that is not useful. And also, you know, we have more uterotropic, we have a progestin with a higher uterotropic index than desogestrel. So maybe in first line, it's better to use this type of progestin if you have to reduce a bleeding. And obviously a higher dose of ethinyl estradiol, because if you use 30 micrograms or 35 micrograms, it's better than use 15 or 20 micrograms. But there are only practical advices. I don't show you meta-analysis. There are practical advice of my personal activities.
Well, keeping on the estrogen addiction in case of bleeding, there is a question from Mausbach, who's asking whether we can use those in cream in the form of cream or spray. But you already said to use the transderm part, so you already answered in a certain way to this question.
Yeah, I normally use them or in a cream or in a patch. I prefer the cream, but you can use also a patch. The study with levonorgestrel intra-use system was that proved not efficacy was done by a patch. I normally use with implants the cream, but yeah, you can use both, I think, with the implants.
There's another question about the low-dose levonorgestrel intrauterine systems. If the bleeding persists after 1 year of use, what would you suggest?
I would suggest if the women want to continue to use an intrauterine system, to have the brave to advise to the women to change with an higher dose levonorgestrel intrauterine system, because since 5 years we have a revolution in intrauterine contraception, that is the customization of intrauterine contraception. And this is also another important topic that we have to follow in the next year. So for which women is every different intrauterine system. So if a woman bleed with a lower dosage, we have to increase the dosage to the 52 milligrams. With no fear, it works. I do it, it works. More amenorrhea, but there are trials showing that. This is not only my personal experience.
We move to another question, different. So we move over from implant, and John Theo is asking, what is the missile pill advice when we use the drospirenone 24+4 pill?
Yeah, with drospirenone only pills, you have to take in mind that we have a dose used that is the double of this required to inhibit ovulation, 4 milligrams in comparison to 2 milligrams, so 200%. So the effect is higher than when you use the Zogestrel, also the contraceptive efficacy. So they have now the FDA approbation that you can also miss the pill for 24 hours and the pill is still active. So this is a very important issue that we have to take in mind with drospirenone pill. If the missed pill is more than 24 hours, obviously you have to take other. You have to also think about emergency contraception or use other contraceptive methods in the additional contraceptive method, as we did for every other hormonal contraception.
There's another question about the implant. Do we need to stitch during insertion or removal of the implants? So Nexplanon, presumably.
Does a stitch? What is exactly a stitch?
Well, suturing. Actually, you don't need a suture.
No suture. No, it's just local anesthesia in the place of insertion, and it's a needle. It's not more than a needle. It's a large needle, but at the end it's a needle. No, I don't put another patch or sterile strip, nothing, because normally the cut in the insertion is really minimal. For removal, sometimes if the removal is quite difficult, maybe you do a cut. And I'm completely agree with Dr. Chaudhry position about the cut for the removal. That has to be perpendicular to the implant, not parallel to the implant. If you read the instruction, it's written that you can cut parallel or perpendicular. In my practice, it's better to do it perpendicular because you have more space to remove the implants. And if you have necessity to do the cut slightly larger, you can put just 2 patch, sterile strip, but not stitch, never stitch.
Did you ever use ultrasonography in order to, determine the place of the implants?
Yeah, I use it, but I think that it's important to see exactly where it is. But at the end, what is important is to know that is here and not away. Okay, if you are sure that is here, and if you are sure that it is not under the muscular fascia, because the real problem if it's the implant is under the muscular fascia, because if it is in the muscle, it's not our side. We have to call an orthopedic, because who wants to open a biceps or a triceps? I not, because I don't have any anatomical knowledge of this side. So you have to call an orthopedic. But if the implant is in the subdermal, also if it is very a bit deep of 1 centimeter in obese patients, it's not a big problem, because obviously you have to cut the subdermal, but with not many risk of complications. So the real complication is if the implant is under the fascia, and under the fascia can happen especially in very thin women, because very thin women, and there are very interesting cadaver study about this issue, have a subdermal tissue that is in the mean 5-6 millimeters of depth. So in these patients, there is the risk that if you go down, you go under the fascia, because the fascia is not so deep. But this is the very complication risk, I think, and also the thing that can complicate really the removal of implants.
Yeah, I perfectly agree with you, Giovanni. And then there is a problem that is really difficult to address. We can discuss this, I think, in Doc Matter, because there are some myths about contraception. And one of these is that the retention of blood can be considered bad. And it's a belief that move women to leave their contraceptive. So I think, Berna, what do you think about it? Shall we pose this question on Doc Matter and follow the discussion over there?
Definitely. Amenorrhea in some cultures is considered as a health risk because the bad blood is not flowing out. Or sometimes amenorrhea is considered as a sign of menopause, early menopause.
Right.
I think we have to discuss, and I think, I don't know what your practice is, but I'm sure it's parallel to our practice. The counseling before IUD, levonorgestrel, IUD, or whatever you're using, I think it's very important that this is an expected effect, and the patient should know that it is safe and it's not against her health. So I don't know what your practice is about counseling.
Yeah, well, usually I do counsel a lot, and also Giovanni, I know he make it. But this is a myth that we should misspell. So I don't think that we have time, since we have few minutes more to discuss. So probably it's better to move the discussion over Doc Matter so we can discuss it better there. And all the rest are greetings for the great presentation, Giovanni, of course, and the meeting. And I'm really happy we could organize this with the help of the central office, which of the European Society of Contraception, which helped us to do it, and the scientific committee, which agree about the fact that we could make this meeting. And at the end of this all, I want to really, really thank you all for having participated in today's webinar. And I thank you, Giovanni. I thank you, Dr. Chaudhry, who is not here. And I thank you also, you, Berna, for being here. And a very, very Merry Christmas and Happy New Year, and greetings for the season holidays.
Thank you, Manuela. Manuela is a member of our executive board of directors, so I have to thank her for this organization, and Dr. Giovanni Grandi for his excellent presentation, and also Dr. Chaudhry. Thank you very much, and have a happy new year, and Merry Christmas and happy holidays.
Thank you.
Thank you, Giovanni, again.
Thank you.